Alright, let's move on to our final cyanotic heart disease. I know you can't wait to be done with this and move on to acyanotic heart disease. So we have preductal aortic coarctation. So what does it mean preductal? It means before the opening of the ductus arteriosus, you have an aortic coarctation. And what is a coarctation? Coarctation is a fancy way to say a narrowing of the aorta. So this is a picture of it over here, and we'll talk about it as we go through the information on the slide. So the pathophysiology. I want you to imagine this pulmonary artery going through the slide and into the lungs, posteriorly into the page. You have the PDA meeting with the descending aorta. So this is the thoracic aorta here with a lot of blood supply because you have a coarctation narrowing right over here, the preductal before the ductus coarctation. And there's such low pressure going through this coarctation that a lot of blood is going to the upper extremities and to the head, and very little pressure is in the distal descending aorta. So as a result, deoxygenated blood or hypooxygenated blood can go from the pulmonary artery directly into the aortic systemic circulation, causing cyanosis. And this pulmonary artery blood will go to the lung and get oxygenated eventually. So the key thing to know is that this is commonly associated with Turner syndrome, 45XO, when you have one X chromosome instead of two for a woman. Aortic coarctation, as we mentioned, occurs in the thoracic aorta, distal to the subclavian artery, which is this right here, but proximal to the ductus arteriosus. And it's due to a vascular accident in utero that caused damage to that portion of the aorta, and as a result you get excessive blood supply to the upper body and very little blood supply to the lower body, resulting in the cyanotic blood going through. So you get upper body hypertension and left ventricular hypertrophy due to the pressure overload that the heart has to pump against. Clinical consequences. At birth, the PDA has to remain open because of the major pressure difference between the descending aorta and the pulmonary artery. Pulmonary artery has greater pressure, so the PDA won't close and blood will still keep going down through the descending aorta. PDA has a right to left shunt, as we discussed, causing the cyanosis, and hypoperfusion of the lower extremities because of deoxygenated blood entering. So some signs and symptoms we should know about. I'm sure you've heard the term differential pulses. That means you have pulses that are different in the upper and lower extremities. As we noticed in the previous image, the upper extremities have a lot of blood supply, while the lower extremities have less and hypooxygenated blood supply. So the upper extremity will be hypertensive with strong pulses, and lower extremity will be hypotensive with weak pulses and cyanosis. Especially the femoral pulses will be affected. You also get heart murmurs with the preductal aortic coarctation as well because of the coarctation itself. You get a systolic ejection murmur when the blood is trying to go through that narrowed part of the aorta at the left upper sternal border or the left interscapular area. And these locations are important. The left upper sternal border is the location of the coarctation proximal to the ductus arteriosus, and the left interscapular area because the aorta is the most posterior vessel found in the thoracic cavity. Now, how do we diagnose this? The chest x-ray 3 sign. This is probably one of the coolest signs you'll see in x-rays, and it's in the upper left mediastinum. So if you look right here, you see these little two humps here like a camel's back. The first part is the proximal aortic knob aorta. Then you have this coarctation, which is represented by this red line, and you also have the descending aorta. So you have the coarctation here, but a normal proximal and distal aorta, and you see this 3 kind of shape as a result. Really cool sign if you see it on the test to diagnose. Echocardiogram for definitive diagnosis as always. And how do we treat this? We want to do a PGE1 infusion to open the PDA. And why is that? If the PDA isn't open, then if there's no patent ductus arteriosus, there's such a strong coarctation that very little blood will go to the lower extremities and the lower extremities will die. But if you have a PGE1 infusion and you keep the ductus arteriosus open, you'll get venous blood going to the lower extremities. Even though it's not the most optimal situation, it has more oxygen than no blood at all. You also give beta blockers to treat the upper extremity hypertension by decreasing heart contractility and heart cardiac output, and you give surgery for definitive management to open up that part of the aorta.